Today's webinar is entitled Audit Smarter, Not Harder. You're going to see what that means in just a few moments. Today's webinar is sponsored by MDaudit. My name is Dana Finnegan. I'm the Director of Market Strategy at MDaudit. It's great to be with you today. Today we're going to have about 50 minutes, maybe an hour, probably not. We'll get you back to what you need to do in due time. But we're really happy to have you with us today. A few housekeeping items is we will definitely be sending you this deck that you're going to see today. We'll also be sending you today's recording so you can listen to that again. At the end, with about maybe 5 minutes left or so, 10 minutes or so, only other thing we're going to do is we're going to ask you to take a poll. It's not mandatory, of course. It's just to see what you thought of today's session and to suggest other things you may want us to show in the future. So feel free to answer that if you'd like. So I want to talk a little bit about MDaudit, just because, again, they're sponsoring this webinar. I work for MDaudit. We are a billing compliance and revenue integrity platform. You'll see these numbers later on. We've been in this space for over 30 years. Really, at the end of the day, we help organizations across the country. We have a nationwide footprint of helping folks make sure that they're absolutely billing compliantly, while at the same time maximizing revenues and reimbursements and understanding their financial risks so they can mitigate them immediately. And really helping you all at the same time stay operationally efficient. I think that's really the difficult piece is how do you do all of those things, stay healthy as an organization, but stay operationally efficient without throwing too many FTEs at it and getting people kind of burnt out at the end of the day. And that's what we're going to show you today. So that's a little bit about MDaudit. I also want to be really transparent that we're going to talk a lot about MDaudit today, as well as what our product can do. This is going to be a demonstration. And then afterwards, we're going to get into some statistics that are going to be hit home very closely with billing compliance folks like yourself and revenue integrity folks. But the demo isn't intended to try to push the product on you. That's what we're not here to do that. We're not here to sell a product to you. We're here to show you folks that there is an easier way to do your audits. In other words, what we said at the beginning, you can work smarter, but not necessarily harder. We already know you're working hard, too hard, I think. I've been with MDaudit for 7 years. I used to be on the revenue cycle side of things. Didn't know a lot about what you auditors did every day, and as I got exposed to it now for quite a while, it's a really tough job that you take very seriously. And this is what we're going to show you how you can do today, again, to make your lives easier. So you're looking forward to what you do every day. Really, what we're going to concentrate in the demo part, in the first part of this session, is some of the things that I hear over and over. Again, I've been doing this for a long time, but these things here are the main things that I hear every day as pain points. And I put up there that they're productivity and efficiency roadblocks. I think roadblocks a nice word. I think they're more like productivity and efficiency killers. But we're going to show you how you can pull your random samples of claims immediately, make it really easy. So you're not relying on IT. You're not trying to do this, writing queries. You shouldn't have to know SQL and other things to try to pull your random samples. That's not part of your job. You should be just auditing. So we're going to show you how you can do that. We're then going to show you how you can easily append your code and quality audits, how you can go in and agree and disagree and make changes without having to do that in messy spreadsheets and in a manual way. After those audits or post-audit, we want to show you that there is educational packaging, educational reporting and packaging that can come from those audits that you do that can be shared with your audience for education and corrective action. We're also going to show you that you can easily track and trend on your providers' performances and other KPIs. And it doesn't have to be just providers. It could be coders. It could be anything, your DRG downgrades, how you can easily track and trend on that. And I have a little kind of sub-bullet there. Can you use AI for this? We're hearing so much in this space about AI. We want to show you how you can use it effectively and not be scared of it. I know when I first started using it, I got a little nervous, but it's very easy to interact with, and we'll show you how you can do that as well. And then finally, what are the tools you need to take a risk-based approach? A lot of folks ask, how do I take a risk-based approach? I don't want to have to audit every single one of my providers every year, once a year. How do I know who are the ones posing the biggest risk? And then finally, something that has really fallen under the billing compliance purview is denials. Years ago, when I asked, are you folks in billing compliance, you auditors looking at denials? Most people said, no, that's someone else's responsibility. We're going to show you how it's now become your responsibility and how you can actually fight denials and understand root cause and take part in that very important process of winning back revenue needed for your organization. So again, we're going to go through all of this today in a demonstration, but it's going to be an educational demonstration. It's not to try to, sell you a product. And then once we're done with the demonstration, you're seeing it now, we're going to go into some really important statistics related to your very own, what you are doing at your organization, billing compliance, revenue integrity. We're going to give you some really important trends that you should be aware of. And these are actual nuggets you're going to be able to bring back to your programs to operationalize and honestly make things better. I will make sure you leave this demonstration with something that can help you in your daily life. Even if that's to say technology, it's not smoke and mirrors. It's something that can really help me with my daily life. So the first thing we're going to do is go in and we're going to take it slow. We're going to show you how easy it is to pull a random sample. And then we're going to explain how that happens because we want you to know the understanding of how it happens. It's not magic. There's a way that we go about doing this. So today we're going to audit Dr. Smith. I'm just putting in my title, really simple. We're auditing Dr. Smith today. I'm then going to choose a group. Really, any software you work with should allow many different groups in your organization to work from it at the same time, whether you're in billing compliance on the PB side, the HB side, whether you're in revenue integrity or HIM, everybody should be able to access a platform at the same time and not get in each other's ways. It's really easy to wrap all of that under security privilege so you can all do your own tasks. So I'm going to be the PB coding quality group, and then I'm going to assign it to myself, Dana. So we're really just kind of setting up our little title page here to house this Dr. Smith audit. Um, let's hit continue. Now this is really where we're going to spend some of our time. First thing you would do when you create any audit is to put in your dates of service. You may want to go back one day to audit Dr. Smith, or you may want to go back multiple years. You can see I've backdated that to 2019. You should be able to go back as far as you want. Now I'm going to go in and I'm going to choose the type of claim I want to audit. I'm going to audit a professional claim, or what we think of as the 837P today. But this same process you're going to see today can be used to audit on the facility side, high risk DRGs for sepsis, ASC surgeries out of your outpatient locations. Today we're going to show pro-fee, but it's going to work whatever chart type that you're auditing. So I now know I want to audit Dr. Smith's professional charges. So what I'm going to do now is I'm going to maneuver these drop downs to pull my sample size. Now, we're going to do one together, and then we're going to tell you how it works because I want you to know that. You're going to see here these drop downs with provider, like rendering NPI and name and all of that. And then things like at the line level, you may want to look at certain modifiers or CPTs or pull their RVU utilization. You may also want to know when they're billing to certain payers. You should be able to be as granular as you want in pulling a sample size. It shouldn't be painful. So let's do one right now. I know that Dr. Smith's rendering NPI is this number. So I'm just going to cut and paste it in. So there it is right there. Now, when I put that in and hit these arrows, I want you to watch this field. It's going to populate in just a few seconds with all of the claims. There they are, 4,200 claims that were billed by Dr. Smith between these dates of service. Now, that's a lot of claims because I've backdated it quite a bit. But that's going to show everything Dr. Smith has done. His E&Ms, his procedures. I want to be more granular, but I don't want it to be painful. So I'm going to go in and say, I also want to know when he's specifically billing that modifier 25. I'm going to do something else. I also know that right now, this is going to be very specific to their E&Ms. So I'm going to say where their E&Ms are between, I'm going to put in the range I'm looking to audit, 99,211 to 99,215. Also going to get very granular and say I really care about when they were billed, in this case, to Medicare Part B. And I'm going to put in one other clause here to show you how granular you can be. Now, this may not be something you run your queries, but we want to show you how easy it is to pull the data. I want to look at certain HCCs. I'm going to say is in this list. I'm going to list out 18 and 19 for diabetes. Now, I've gotten very granular here, but it's still easy to hit this button and watch. 82. So I went from 4,200 claims down to 82 because the system was able to accommodate that. Again, I'm not asking IT, I'm not maneuvering it through spreadsheets, just pressing an arrow and having that data at my fingertips, AKA helping me stay productive and efficient. Now, how does this work? Okay, we're going to give you a quick 30 seconds on that. Any platform worth their weight will have the ability to ingest your claims and remit data on a daily basis. So those ANSI standard 837Is, 837Ps, and the 835s that come back with the payment information and denials, any platform should be able to ingest those on a daily basis. They don't have to directly integrate with your Epic system or whatever it may be, IDX, Meditech, whatever it is. Don't have to go in and directly pull it out. Rather, the source of truth is those claims. We can suck them into our database every day. So when you go in and say, show me this on the left-hand side, it will be immediately brought to your fingertips. So I think this part is important, the 82 claims now that you've asked for, but the bigger piece is the sample size. This is what we talked about. It shouldn't be painful to get the sample size out of that 82. Shouldn't have to run macros or do anything like that. So I'm just putting in a sample size of 10. I could have put in 20 if I wanted, but that's going to allow me to get a truly random sample of 10. Very similar to how RatStats does the randomization. So now I'm going to hit continue and create audit. And you're going to see the system is spinning. That's the algorithm being applied to pull you that random sample. And now we're going to wait for that to load. But as we're watching it load, I want you to think about how long is it taking you today to get that sample size? And where is it coming from? And are you waiting for it? And when you get it, is it in kind of a unwieldy spreadsheet or do you have to get it through a very manual process? So again, in just a few clicks, we were able to show you how you could go from tell me what I need to here is what you asked for. So now I have a work queue of the 10 claims I asked for, and I can go in and start to do an audit. So just remember, it is very easy through the right technology, and I'm going to be clear, the right technology to pull that random sample. Although it's based on claims data, and we all know claims data is standard now, it's not easy for a vendor to do this. It's very hard, as you know, to take in remits and claims and really parse them and make them look nice like this in front of you. So very few vendors can do it, but there are vendors that can, and you want to work with those vendors like MDaudit. So let me explain what you're looking at right now. We very successfully went in and pulled our sample size. Now, what we're looking at is what went out on that claim. Now, I want to be really clear. You're seeing claim information, but of course there is no PHI. This is all de-identified. There's nothing in here that we shouldn't be seeing. Now, at this point, you're going to have all of your diagnosis codes here in the upper part of the view, but also everything at the CPT level. Now, one thing I'll mention, and I know I'm getting really granular here, is I only asked for modifier 25 when it was billed with level ones through fives. But I got these other line items. That's important. A lot of vendors, when you tell them, I just want to see certain things, you're just going to get those certain things. But you want to see everything that went out on this claim because you want to go audit that too in some cases. But let's go in and do an audit. So the first thing we said we were going to show you is it easy to pull a sample size? Yes, it is. Now we want to go in and show, is it easy? Now, it's not easy to audit. Auditing is something that is incredibly hard to do. We know you work hard. You have licensures to do this. You went to school for this. I'm not putting that in the background. That's incredibly hard. What I'm saying is easy is with all that knowledge you have, how do you apply it? And I want to show you that today. I'm going to show you certain things you can do, like agree with what was billed and coded. How you can edit it. There's obviously the times you go in and things are not meeting the highest level of accuracy and integrity, and you need to edit it. There's times you need to add stuff, meaning you look at that document and there's something that was very well documented and was not billed and really should have been. You don't want to lose that revenue. You want that going out on the claim. Even where you can remove things, that would be where something was billed and shouldn't have been. You want to bill compliantly. What is in the record is what should be on that bill, as you all know, and in auditing aids as well. So let's go in and do that. And I'm going to be transparent. I'm not going to do some of the auditing I do is not going to be how you do it because I'm not as seasoned as you, but we're going to show you how easy it is to do. Now, anything on this screen that you have to audit and you agree with, you can just touch it. So let's agree with the first three diags. I'm going to touch them, scroll down and hit agree, and they turn green. So again, anything you have to audit and you agree with, you can just touch it and very easily say you agree, and that will turn green. Green's always a good color. Now, editing. We're going to edit up here in this diagnosis section and down here in CPT land. But let's go in and show you how to edit it. So some things that should be offered in any system for an auditor when you're editing and doing your coding quality review is you want to see the before, what was billed, Z68.32. We are going to go in and put in the actual supported value. Now I'm just typing this in as Z68 point, let's choose not 32, but we're going to say 22. That obviously happened after you did your review of the documentation. But I'm going to change it to this value because it's more specific. I want to bill 110% compliantly. I'm then going to put in an audit finding. This is a drop-down list that we have, but anyone can really go in and customize it to what they want their naming conventions to be. Any good vendor should start you out of the box with audit findings, but you should be able to add your own as well. So I'm going to say diagnosis disagreement because that's pretty apropos for this. And you can see when I put that in, it weighted at a 0.25. If I decided that it wasn't just a plain old diagnosis disagreement, but a potential overpayment or an underpayment, I'm going to obviously want that weight to be a little bit more. So think of that. Any good system you work with should not only allow you to customize your audit findings, but more importantly, how you would weight and score those. That weighting and scoring will output into an overall accuracy rate here for Dr. Smith. Or if we were doing a DRG audit, those weighting and scoring mechanisms are critical to understand outcomes and accuracy rates. And those accuracy rates then allow you to see who's doing good, who's doing poorly, who needs to be educated. So a weighting and scoring system in any vendor is critical, that they can work with the one you're using right now or show you best practices as how you should be weighting and scoring your providers. And finally, there should be a section where you're able to go in and put your comments, as I'm doing right now. I'm free texting in some comments I want Dr. Smith to see, or my coder. I can use this to audit coders too. I can type those in free text, but I can also, again, I say any vendor worth their weight should give you a library. We want to save typing time. The more typing time we save, the more time you have for education. So there's hundreds in here. You can customize your own. I'm going to choose that because it just saves me the typing time and I'm going to add it. Now I have a full record that I can share with Dr. Smith as to why I made that change. And when I save that, it turns red. It lets me know that that's something I want to cover when I'm educating Dr. Smith or Coder Jane Smith. So that's how I can agree. That's how I can make a change. Let's do something else. Let's say this chronic kidney disease. I don't like, I didn't see enough in the documentation to support the billing of it. That's where I'd remove that row. It'll go in and show me, okay, here's the diag that was billed, but unfortunately, there was insufficient documentation. And because I want to be compliant, I am going to remove that row. And I'm going to put in my comments and I'm going to hit save and it's going to remove that row. Now I'm done with this section up here. I want to do something else. We've shown you how to agree, how to edit, how to cross something out. Let's say you go in and you see that this provider has done everything in the CPT section, but you've also seen something else they've done that was well documented, but not billed. Let's add it in. I'm going to put the earwax removal in. I'm going to put the date in. Obviously, dates of service are important in units. And of course, what's the place of service? And you're seeing all through drop downs, you're not entering this into a spreadsheet. You're not manually typing it. Every little nuance is saving you time. And what does that time put towards? Education. I'm going to put procedure documented and not billed, and I'm going to save that. And it adds it in there for me. So we've really kind of tackled the first two things we talked about. One was let's pull the sample size immediately. Part two, let's get into the audit and audit seamlessly. Let's go to one other couple of places during an audit. We've all been told when you're doing audits, you need auditing aids. And the one thing I hear from auditors is I don't want to have to leave a platform I'm using and spend 5 hours looking for a publication. So along with this, we have an annual wellness visit. You see that right there, the GO439. I may want to use an auditing aid. A risk area worksheet is what we call it, to make sure I'm asking myself the appropriate questions to see if that annual wellness visit can be billed or not. So I'm going to pull up my annual wellness visit auditing aid. Now, we won't go through all of this today, but any vendor worth their weight, as I said before, and you'll hear me say that again, is they should be saying, they should know things that are being scrutinized by the OIG, RACs and MACs, MLN matters, you name it, CMS. Anything that's being scrutinized should be turned into an auditing aid. And you'll see here, you can ask yourself a set of yes and no and drop down questions and check off questions. What we've done here is we've looked at that publication and diluted it down to a consumable set of questions that you can ask yourself. And I'll let you eyeball these. They'll be very familiar to you that allow you to come in and say, by the time you answer that last question, you're going to have uber confidence as to whether this can be billed or not by just asking the questions. And if you're still a little antsy, we don't want you to not have confidence. As you're answering those questions, there'll be worksheet findings going on in the background, letting you know whether you can bill this or not. So just in the same process of pulling your sample size and appending your audit evaluation, make sure that whether it's LCDs or NCDs or med-nec policies, that there is a host, and you can see them here as I scroll down, risk area worksheets or auditing aids that will help you make those tough decisions you have to. I always get asked, do you have things for incident to billing? Yes. Do you have things for split shared billing? Yes. Critical care? Yes. Again, you don't want to be working in a system and then have to leave it and spend hours reading a publication and figuring out what those questions should be. They should be at your fingertips, and they are in a good platform. I'm going to say I use that sheet and everything looked good. The last thing we're going to do from here is take a look at this E&M, 99214. Of course, some of you, many of you can edit that because you just know it's a level 2 or a level 5. You have that experience. Someone like me, I may need to use an E&M worksheet. So along with, if you don't know what that level should be, you should always have access to a worksheet that helps you decide or helps you, that you interact with that worksheet to say, is this a level, is this a level 4 or is it not? So I'm going to go in and just show you what a worksheet like that would look like. And we won't go through it in its entirety, but it's going to show you this is what's being billed a level 4. But the auditor, with their absolute expertise, will be able to go in and fill out what's happening in the history, in the exam, and the medical decision making and time and category. You guys do this every day. I'm just going to click off a few things I'm seeing. You guys are obviously a lot more tedious than this, but as you're checking things off, you can see here it's saying it's a low decision making, but I hit this arrow, it's telling me it's not a four, it's a 3. So again, you're doing the work, but you have an interactive worksheet that helps you make these really tough leveling decisions. So just wanted to show you that along with pulling the random sample, appending the audit evaluation, and having those auditing aids at your fingertips, you're going to have a really good experience and again, stay very productive. None of this, or a lot of this is allowing you to move away from a very manual process. So we're done auditing this claim. I'm going to put it from a new status to a completed status. And I'm going to save and close out of it. And just to show you what a good work queue would look like for an auditor is you'll see that case status will be right here. You've completed it. You can move on to your next claim. So folks, right now we've walked through the audit sample, how to append the audit evaluation, and even use auditing aids. Now I'm going to do something really quickly here before we move on to some of the educational reporting that can come from this. Because I know one of the things that people tell me they cringe is they finish the painstaking audit, but then they've got to spend hours and days and weeks sometimes putting the reporting together. But I want to show you one quick thing. I can see we have a lot of facility folks on here too. So we're going to quickly do a DRG audit. Same thing, we put in our title. We're going to choose our group. We're going to assign it to Dana again. One thing I didn't show you in the first one when we did a Profi audit was any audit you do on our system or any system worth its weight will allow you to do it prospectively and retrospectively. Now, there's obviously some major technical underpinnings to that we've mastered, but for an auditor, you should not have to worry about the technical underpinnings. You should just be able to say, as I'm doing here, today I'm going to do a retrospective audit. Tomorrow I'm going to do a pre-bill audit. So again, you should have the ability to just flip the data source and not worry about the technical underpinnings. That's not your job. Let the technical engineers figure it out. So today we're going to do retrospective, and I'm going to hit continue. The good news is I'm still going to put in my dates of service, but I don't have to learn some other fancy smancy workflow. I can just flip this from professional to hospital. And I'm going to have those same drop downs, except the drop downs here are going to represent what can go out on a facility claim, inpatient or outpatient. I'm going to quickly just say, show me where my DRG, I'm going to say, is in this list. And if I've heard it once, I've heard it a million times, everybody's worried about sepsis. So I'm going to put in those sepsis DRGs. And I'm also going to say, show me where the length of stay, should be able to look at length of stay for your really acute patients is greater than, we'll say 20 days. And one final one, and I know this is very repetitive to Profi, but I know we have a lot of facility folks on here. I'm going to say Medicare Part A. I'm going to hit that. And I get it right away. I mean, that is very quick. We're going to put in our sample size again, hit 10. Hit continue and create audit. And just like we did on the Profi side, a technology that you decide to work with should be able to allow you to do it on the Profi side and the facility inpatient and outpatient side without having to learn something for each one of them. It should all work the way you're seeing right now. Easy, intuitive, and just very, very straightforward. And this time we won't go into it because it's pretty straightforward, but this time we're just going to be looking at the inpatient claim. Now, it's important, you've got your diags up here, all of your other information over here, DRG, external causes of injury, procedures, everything at the revenue code line level plus units and charges. But a lot of vendors struggle with this piece, not us, but you should also be able to go in and audit admit type, admit source, discharge status, admit date. Very easy to go in and do audit any of this stuff. So I'm going to say it wasn't to a home health, it was actually to home. Going to put that in, and we're going to disagree. And maybe we make a note here to our coder and share this with our coder. But all of this stuff that goes out on this 837I, or what we think of as the UB04, should be able to be audited that easily. One other thing I'm going to show before we move on to some other stuff is financial impact. This is where I see the build value as sepsis without event. I'm going to put in sepsis with event. So we're going to put in where it had event. Now, if I do that, my most apropos audit finding would be that the original billing of that was a potential underpayment because it didn't have event, and now I'm saying it does. Certainly going to want to put some comments into my coder, and then I'm going to hit save. And what you'll see is not only can we track coding quality changes, but payment information. So when that was billed as an 871, it paid $17,000. But when you went in and made your evaluation, the supported payment was actually $58,000. So you incurred an underpayment of $41,000. So any good system should be able to track and trend on your coding quality review, but also the payment integrity, overpayments and underpayments. And how that helps you is traditionally we all know that billing compliance has been considered a bit of a someone that just looks at coding quality. But if you can go and show statistics on overpayments and underpayments you're finding, you become a rock star, because every CFO across the country now is trying to guard against underpayments because they want to recoup that revenue. But now, as we hear with Doge in the market and other things going on, overpayments are being highly scrutinized. A lot of clawbacks from that. So if you can identify overpayments and underpayments by just doing your coding quality review, you again become a rock star and really start contributing to the health. You already contribute to the health of your organization billing compliantly, but you bring another really cool element to the table. So just keep in mind, any good system should be able to do that as well. So now what I want to do is get to like a really cool part. And what I'm going to show from this is how to take, we're going to get into reporting in a moment, but I want to show something a little different. What we just did there was we audited from scratch. I like to say from scratch. We basically used the approach you could use to say, someone comes to your desk and says, you need to audit Dr. Smith. Well, you need to audit sepsis DRGs because OIG is scrutinizing them. That's how technology can help with that. So let's move on to another part. How does technology help you take a risk-based approach? Meaning, most people, before they come to MDaudit, these are all bubbles representing all of the physicians billing and E&Ms. And what a lot of our auditors are told before they come on MDaudit is you have to go from left to right and audit every single one of your physicians once a year, whether you have 100 physicians or 10,000 at your organization. And at the end of the day, it's a nice mandate, but it's not really doable. You can't do it without some sort of technology. So I want to show you how technology can help you do that. So let's pretend these are all of the physicians that are billing E&Ms at your organization. Again, whether you're an organization that has 100 physicians or 10,000. The middle of this grid is going to represent your physicians that are billing those E&Ms appropriately. Their E&Ms are spot on. You want to be able to, at the end of the day, weed out anyone in the lower left. That's going to represent your physicians that are habitually undercoding. You want to find them because that's a loss of revenue. But we also want you to be able to find the upper right of physicians that are habitually overcoding and exposing you to risk. We don't want you to get letters from payers, Blue Cross, Aetna, the government saying, send us medical records. We're going to claw back some money because you're overbilling. We want to protect you on the lower left and the upper right. So how do you do that? Not saying you have to ignore every physician in the middle, but how do you make your day more manageable? So what we can do, or what you could do, and again, I say vendors should be able to offer this. MDaudit's really the only one I know of that does. But you should be able to bump your providers versus CMS, meaning what does CMS consider normal E&M leveling patterns by specialty? You should also be able to compare to, in this case, this is the MDaudit community. So if you became part of our community, you could compare yourselves to other organizations doing the same type of billing. You could compare your gastroenterologist at your organization to all the gastroenterologists in the MDaudit community, peer to peer. And when you join the MDaudit community, you can even get down to certain payers, even processing region. But let's use MDaudit as our benchmark. It's called a benchmark. So now you're benchmarking your providers against those in the MDaudit community. Next thing I'm going to do is put in an E&M category. They're all in here. You may want to look at the high dollar consults. Today, we're just going to make it easy and say established patient. You should then very easily be able to go in and choose the specialty you want to look at. I know a lot of the auditors, you're assigned to certain specialties. So today I mentioned gastro. So let's put in, well, let's do internal medicine. And then within it, you see the bubble start to move. That's good. Then within internal medicine, I'm going to put in, you could put in any specialty, but I'm going to say gastro because that's what I said. And at this point, what you're seeing is across all of your facilities, of every gastroenterologist that's billing out of your facility, when compared to other gastroenterologists in the MDaudit community, just doing the same type of billing as you in the same regions, the same provider counts and payer mixes, you've got a real big bubble down here. That's someone to worry about that's undercoding. I'm also not going to worry as much about this doc that's overcoding because it's a small bubble, but I'm still going to look at him or her today. So it really, again, and that was a drastic kind of removal of the middle, but that's what it can do. You can say, you've only got a certain amount of hours in the day. You've got other things you have to do. You have to meet folks for education. You have to respond to payer audits. Let's take a look at this doc because he or she is the one creating a lot of noise or a fire we may need to put out. So I can just click on that bubble. It's helped me understand the risk-based approach, get me there. Now I want to see the next thing, which is their bell curve. I know many of you, obviously all of you have used bell curves your whole lives, but let's kind of show you what this can show. Picture being able to show this to your physician in gastro. You could say, hey, Dr. Smith, 92%, almost 100% of your established visits are going out as this level 3. Really no level 4s going out, barely any 5s. That's the provider MDaudit's found at risk. This yellow line's a great internal benchmark. That's where you could say every other gastroenterologist at my organization working in the same department as this provider is only doing that 54% of the time. Really big delta between that outlier physician and his peers. But the most important one is the blue. That's the normative benchmark. That's the MDaudit community. And I can flip that to CMS, but what it tells me is everybody else in gastro is much more in alignment with what's normal, what MDaudit community, what other gastro docs are doing. This doc needs to be audited quickly. So that's great, helps you take a risk-based approach, but how do you, the main thing from here is how do you audit them right away? Again, how do you get that sample size immediately? Well, let's show you how we kind of wrap a bow around that. We were here at E&M utilization, but we also have a risk areas dashboard. And I think this is something that whether you're doing it through technology or you're not, you need to have a similar risk area vantage point, which will show you essentially this target column. This is listing out any and all providers that are suspected of overcoding and undercoding. So just picture, those are for physician names. You should also know what type of financial risk they're posing. An audit risk is someone that's overcoding habitually and could really lead to getting an external audit coming from a payer. A revenue risk is someone that you need to look at because they're losing revenue possibly through undercoding. So you shouldn't just know who they are, but what type of financial risk they're posing. And then obviously a weight. We won't get into the weight, but what any good technology will tell you is if you come here and let's hope not, but you have 25 physicians listed for overcoding and undercoding, who do you audit first? Who do you audit last? How do you put out the fire quicker? Well, 6 in our system is someone that you have to audit immediately. 3 2s and 1s, you can wait till the next day or next week. After you have that ranking, what you should be able to do is easily understand what makes up that ranking. Like this is a urologist or a gastroenterologist. They're overbilling services compared to the benchmark. It looks like they're struggling with their level 4. Could show other codes. And then more importantly, how much billing is going out the door. That's a huge sign of risk. But at the end of the day, risk ranking and all that is great, but you then have to audit them. That's where if you work with a platform that can truly, what we call seamlessly integrate from analytics and risk ranking to a workflow, can that be done? If you're interviewing any vendor, you should ask them, can they do this? Ask them, you've shown me my risk. Can I create an audit from there? I think 10 out of 10 times vendors are going to tell you, no, sorry, you got to go back and grab the claims from your system yourself. This is where you can click create an audit, and it will launch you from that risk profile of Dr. Smith, the urologist that's off the charts for overbilling, back into that workflow that we use to create audits from scratch. You can easily go in again and say, I'm working with the code and quality group. I want to assign that to Dana. And by just hitting continue, a smart system should be able to provide you with this. You remember from just a few minutes ago, we went in and grabbed from these drop downs. Any good system's intelligent enough to say, by looking at that provider's risk profile, they're struggling with their level 4s. It'll know their NPI. It'll even know the facility they're working at. And just like you did before, click the arrows. It will find the at-risk claims, put in your sample size, hit continue, and create audit. And we're going to go to the same place we just went to, but the point being is, and again, if you're interviewing vendors, you should always ask, I like your analytics, but can you back into a workflow? And that's what this looks like. You went from our system MDaudit telling you Dr. Smith is where the fire is to having immediate access to his or her claims so you can go in and do that coding quality review that we did in part 1. And that, folks, is a high level, but that's how you can also use technology, not to just pull the random sample, not to just audit from scratch, but to help you take a very risk-based approach. Again, don't spend too much time in the middle of the physicians that are coding well. Get to the outliers and tackle them immediately. And that's exactly what a good technology can help you do. I would also mention really quickly, that's a Profi example. Any good system will also be able to look at things, and we're going to concentrate. I'm going to find one right here for you. Any good system should also allow you to get alerts, meaning any good system should be able to interrogate not only your Profi claims, but your facility inpatient and outpatient claims and let you know where you're billing outside of normative ranges. So we're not going to get into this today, but this is exactly where I'm seeing that my organization is billing surgical DRGs with CCs and MCCs about 62% of the time out of a certain facility. But others just like me are only doing that 55% of the time. What does that tell me? It tells me I may be overbilling or overstating those CCs and MCCs. We all know those are being highly scrutinized, particularly by Medicare Advantage. You can get really hit hard with penalties from billing those out to Medicare Advantage plans. So I want to know, why am I doing 63%? Others are doing way less than me. Again, immediate ability, whether it's on the Profi side or the facility side, to go and get those claims that make up that anomaly at your organization, click off a sample size, and create an audit. I won't launch us into that workflow now, but just like with the E&Ms, MDaudit and any good system can look at all of your billing, again, on a daily basis and throw alerts at you of what you should add to your audit plan. Again, we started off by saying auditors have a really hard job. They're asking you to do things you can't possibly do in a day. Let technology act as an FTE on your team, showing you where you need to concentrate. So the point of that is any really good system should allow you to see those anomalies and tackle them immediately, whether it's on the pro fee side or the facility side. Okay, we're getting towards the end here. I want to show you something else, and I think this is important for billing compliance folks. I remember a time, even up to 3 years ago, when I said, do you folks in billing compliance look at your denials? And a lot of it was no, I'm really concentrating on coding quality. The denials are really for revenue cycle, and that's fine. That may be the way it works in your organization still, but we're seeing a huge transition of billing compliance folks looking at their denials. So we're going to go in and just show you something really quick here. We won't get into all of it, but let's take a look at this. You guys in billing compliance, you're not going to worry about patient access. You're not going to worry about certain things, but you're certainly going to worry about coding denials. They fall under your purview. So what you're able to do on any good system is track month over month, what do my coding denials look like? Hopefully you're seeing a lot of this trend where they're going down. But if someone comes to you and says, hey, Dana, we've seen a huge spike in denials, coding denials that fall under your purview. Why is it happening? You don't want to be caught off guard and not have an answer, or spend 5 hours of your afternoon trying to figure out why this spike has happened. So click on the two places where it's spiking and use AI. So I remember, I mean, I'm was nervous a little bit about AI. It's so new to our space, but I can run a change analysis, which is AI that will go in and look at that spike and tell me why it's happened. So if someone shows up at my shoulder and says, it's been a huge coding bomb that went off, a lot of denials, why is it happening? Hit those 2 points, and you can now say, well, the reason, and AI is able to show you anything that causes a significant change. The reason is there's a lot being billed out this month. You can see that's non-covered because it's not a medical necessity by the payer. Okay, not meeting med necessity. Next question they're going to ask you is, what's the payer? So you're going to go to payer and tell them that it's really this payer. Looks like United. Next thing they may ask is, what is the account numbers? We may want to go and see those account. Okay, it's really one account number that's getting really bombarded with denial. They may even want to know certain things like, what facility is it originating at? I may even go in and they may have a question that they ask and say, well, who's the rendering provider by name that is having the issue? And I can put that in and just ask, let me tell you who the rendering providers are. It's really just one rendering provider. So you're able to go in through the AI for denials under your purview and have those answers. And the point of this is, if you understand root cause immediately, you're going to be able to spend a lot more time with successful appeals. And giving that information to the stakeholders in the billing office that need it to do those appeals. Or it may be refunds in some cases, but let's just reset. You don't want to have to spend hours figuring this out. You can have technology help you understand root cause. And if you happen to be in patient access, if there's anyone here from patient access, or you're tracking CMI, the same type of stuff can work for you. Now, one last thing I'll show is payers. And I'm more doing this because I want to show you the technology can be intuitive and easy to use. So when I first look at this, I see my payer mix, all of month over month, all of my payers that are denying me over here. But what I like is the ability, and a lot of vendors will have this, or not a lot of vendors will have this, I should say, but you're able to go in, and if you just see, you can see here, wow, I'm not going to worry about this payer. The denial rate stayed pretty much the same, but I may go into this one where it's rising, it's continued to rise. I can see it easily and then drill down and say, well, again, what's the reason? So I don't have to use AI. I can just ask the question myself, and right away I know I've got some non-covered charges. I've got duplicates, but if I want to know the non-covered charges, my next question may be, what were the CPTs or the HICS picks? What's not being covered? And it's going to tell me that. And right away, it's telling me the one thing that just remember, you shouldn't just, your responsibilities are expanding and you should understand coding quality, but also get your hands on the denial information as well. And in AI and a lot of this technology can help you. So what I'm going to do right now is I wanted to show some reporting, but I also want to get to some stats we have. So what I'm going to do right now, and I'm going to save some time, is cut to my original presentation that kind of shows you some cool stats. So let me just put this up. And this is going to directly relate to the billing compliance audience. Because I want you to see this. We said that you're going to send you home with some nuggets. So let's talk about some stats we grabbed from our benchmarking report. So MDaudit every year has a benchmarking report that tells us what's going in on our community, what's happening in the MDaudit community, the auditors that are auditing in our community, what are they seeing? Well, really quickly, when the use of technology that you've seen today, we saw folks that recently adopted that technology that they saw a 35% increase in the number of audits and cases they were able to do. That's, again, going back to easily being able to pull a sample size, easily being able to take a risk-based audit and so on. So know that technology can support you to become more productive, more efficient. The other thing we would say is, this is really important. If you go away with anything, 5 years ago when I started looking at these stats, everything was being done retrospectively. Now we're seeing, that there's a 275% increase year over year from 2023 to 2024 in prospective audits. Please, 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 if you're not employing a blend of prospective and retrospective, find someone that can help you do things prospectively. That is going to increase first pass pay rates, reduce days in AR, and it's going to allow you to bill compliantly on the first pass. So just know, in communities using technology like MDaudit, prospective audits are the norm. I would also say, and we talked a little bit about this when we grabbed our random sample with HCCs 18 and 19, that there's been a massive increase from 2023 to 2024 in HCC risk-based audits. If you are billing out HCCs, MCCs, CCs to Medicare Advantage plans and just any payers, definitely have a way to both retrospectively and, more importantly, prospectively audit those HCCs. They're under incredible scrutiny. Another statistic that I would just throw you out there is, in our community, when providers were audited, more than 25% of providers failed audits. So it's not a small amount, it's not a huge amount, but that 25%, if you extrapolate it out, can be crippling. So you want to know the reasons why they're failing. Not only do you want to audit them, like we showed you how you can through the demo, but you want to know the reasons for failure. And you'll be getting this, so you can take a look at why they failed and see if that's the same reasons they're failing in your organization. So we'll give you all of these stats. But takeaway is, you want to be auditing all of your providers, or at least the ones that you're seeing that show up on your risk-based approach. And the other thing I would mention here is just denials. We talked about denials. I won't go into all of this, but despite, and I want to really call this out before the end of the demo, despite everything happening with autonomous coding and all the things you're hearing about scrubbing engines, coding-related denials in the MDaudit community increased by more than 100% in 2024. And you can see here, on the pro fee side, the increase from the year before was 24%, outpatient side 32%, but look at the inpatient side, 219% increase for coding denials. This isn't patient access, this isn't credentialing, it's coding. And that's why we wanted to show you the part of how you can drill down to coding denials. If inpatient, long length of stay, a lot of money at risk, if you're not geared up to tell people why those claims are denying, they're not going to be happy. So you need something to tell you what's causing that increase. So folks, just a little bit from our benchmarking report. Again, you're going to get this slide, these slides, to understand why things are happening, and you're going to be able to take these nuggets and work them into your program. But that's what we had today. I am going to stop right now. Rachel, if you would launch the poll just so people can take that, I'd appreciate it. I'm actually going to dig into the questions. I have a bunch here. And let me just grab those. Okay. So the first one, and I think we answered this, was how do you pull the 837I and ANSI files? Okay, so that's obviously a little technical above my technical expertise, but what I would say is the 835s and 837s, both I's and P's, as those are produced and billed out directly to payers or through clearinghouses, MD Audit has the ability to bring those back into our platform on a daily basis. They go to a secure SFTP server housed on Amazon Web Services. We are HITRUST certified, so we have technical abilities to ingest those into our database on a daily basis. So it doesn't require anyone to have to doesn't require us to have to fidget with your billing systems and your EMRs, which is what you don't want. Another one I have is what is the best? Let's see. I'm going to get to a question I think you'll all want. Oh, I may have missed it, but for professional audits, do you have the okay? Do you have the option for prospective and retrospective? Yes. So for any audit you do on our system, whether it's a coder audit, a physician audit, HB audit, it can all be done prospectively and retrospectively. Oh, here's a good one. Can you explain the admin button? That's a great question. When we were changing things, we were at that point weighting the physician or the coder kind of in a penalizing way because they made a mistake. But if there's something you want to audit, but you don't want to penalize the physician or the coder, there's an administrative button that would allow you to click that, which says, "Hey, you did something wrong, but I don't want it to be held against you in your score." So you don't have to hold it negatively against the provider. Um, I will also answer. I'm trying to read the question. It's a long one. Oh, okay. Can you audit coders on your platform as well and give the same scoring as providers? Okay, good question. This will be the last one I answer. You can also audit coders on our system. So one thing that we are able to do really quickly is there's certain things that don't go out on the claim and certain things that don't come back on the remit. We can bring things in through what we call supplemental data. A lot of people want to audit coders or clinical trial numbers or risk of severity or severity of illness, risk of mortality. Just because it doesn't go out on a claim or come back on a remit doesn't mean you can't audit it. We do have the ability to match up the claims with who audited them. And when you're auditing coders, you can apply the same weighting and scoring mechanism as you do to your providers, or we have the configuration that you can apply a different scoring system to coders. It's up to you. It's highly customizable. Um, and the last one I would say is if it's something about diagnoses. So if I'm reading the question right, when you're changing diagnoses, you can change not only the diagnosis, but the order it should be in. So you can move it from 3 to 1 or 1 to 3. And the second part of that question is, will it change the DRG? It doesn't change the DRG. That's something you would still perform yourself. We don't offer the encoder technology, but it's very common for folks in our organizations to be using an encoder along with our system. So I'm sorry I can't get to all of these questions. We'll certainly get back to you. But thank you for your time today. Again, you'll be receiving the deck, the recording. Feel free to reach out to us. Again, we're not going to push a platform on you. I'm happy to meet with you and share best practices. But thank you for your time today. And I'm going to let you go a minute early, and hopefully you've left some insights of what we can present to you in following months. Thanks very much, and thanks for everything you do as well. As I said, you have a very hard job, and keeping organizations compliant is at the top of a list to keep organizations whole. Have a good day.